Hello, and thank you for joining us again on this podcast today. It will be a very informative session, and I have the honor here to have Chris Denton. Is Professor of Experimental Rheumatology at UCL London, and of course a world leader and expert in the field of scleroderma. Good morning, good afternoon, Chris.
So Francesco, it's great to be here and on the forum and to be talking about one of my favorite topics, really, which is the role of autoantibodies in systemic sclerosis in scleroderma.
Exactly. So when we decided to do this argument, it was suggested by the steering committee. Of course, there was no better person than asking you. Your work has been inspiring in this field. And really, I would like to spend the next 10, 15 minutes to get your opinion that has been informed by all your studies on what have we learned on the autoantibodies. So we could start perhaps from their role in the diagnosis, and how important they've been in supporting diagnosis in scleroderma.
Yeah, so of course. So I think, the autoantibodies really are I guess a constant reminder to us that systemic sclerosis is an autoimmune rheumatic disease, an autoimmune disease where the sort of breakdown in humoral immunity tolerance is sort of cardinal. And I suppose the thing that I've always been struck by is that the autoantibodies that we use to diagnose scleroderma, systemic sclerosis, also have these very clear associations with risk of complication. And I've worked on this using our large cohort of patients and also collaboratively with USTAR and with other centres internationally to sort of understand that better over the last 2 or 3 decades. But of course, building on the shoulders of giants, particularly the work that Ginny Steen, Tom Metzger and others did from Pittsburgh, that sort of was really seminal. But I think the first thing to say about the autoantibodies in systemic sclerosis is that there are obviously the common antibodies that we use, the anti-centromere antibody, the anti-SCL70 or topoisomerase, the anti-RNA polymerase 3. And there's an important group of patients that have systemic sclerosis but don't have a defined antibody, although they are anti-nuclear antibody positive. So presumably there are still more antibodies to discover. But then there are also this group of less common antibodies that are also important and that perhaps sometimes overlooked, the antibodies like THTO or fibrillarin. And each of these antibodies, I think, we know now, and certainly from studying our cohort of patients, each antibody is associated with almost a different clinical subtype of scleroderma. And I suppose, or systemic sclerosis, and I suppose the key thing that I learned early on from my clinical practice of sort of seeing the patients in the clinic was clearly the antibody associations, the clinical associations, seem to cross the skin-based subsets. So that was really, the sort of start of the work that we did and published Absolutely. In 2020, where you kind of could integrate skin subset and antibody to kind of help you classify patients better. And I think that, work from others and USTAR.
Of course it does. It does. And this is, of course, is true in scleroderma. It's been true in scleroderma as one of the main biomarkers in scleroderma, that it's in every textbook. So it's far from research. It's very applicable. And it's true in the other connective tissue diseases where we've learned that these antibodies, they mark a specific phenotype. We've been doing that for decades. But now, and thanks to your work, we're learning why, right? It's not just an epiphenomenon, and they could be linked to a specific type of biology. And this is really a new field now. So what we use for decades as a test to screen for some complication versus others, now is teaching us about the biology. What have you learned?
So I think, one of the early observations, I suppose, was that for the majority of systemic sclerosis patients, they will have one of these hallmark antibodies, but they will generally only have one. And that was kind of for a number of years, that was a little bit of a puzzle, but I think it all got kind of much more elucidated really from the genetic studies and the immunogenetic studies that have really shown initially just by, the classical association studies that were done in the sort of 1990s, but now up to the sort of very cutting edge studies done by Javier Martin in Spain and others, that really show that the autoantibodies are very closely linked to your HLA haplotype, to your MHC, and really the autoantibodies therefore reflect more about the immune system and its ability to recognize autoantigens. And I think that fact that the autoantibodies are mutually exclusive, so you have one antibody, but are very unlikely to have another one, that is really what underpins, I think, their utility for the classification. So I think that was the first bit of sort of science that was very interesting. And I think, as you say, it's informed clinical practice.
Yeah, absolutely. And that's interesting, of course, because it could reflect in this sense, there could be a serum marker of a specific genotype. Yeah. But then you went beyond that and you found that there were some specific transcriptome signatures associated with antibodies, with specific autoantibodies, and also biological evolutions over time. And that really now, to me, is bringing it to another level, because it's generating the question of whether these antibodies are an epiphenomenon or they are directly linked to the process that is to the tissue damage.
Yeah, so I thank you for highlighting the work that we've done, and Christina Clark was a big part of that, working in our unit and others over the last 5 or 6 years. But again, I think one of the sort of concepts behind that was the fact that as we've got these really sophisticated high-dimensional platforms now to do genomic and proteomic analysis in patient samples, skin and blood and so on, it seemed to me that the autoantibodies and those sort of exclusive associations would be a very good anchor, if you like, to try and deconstruct or decode the biology of those high-dimensional data sets, because you get so much data out of a genome-wide gene expression study, etc. But you kind of need to anchor that, and it seemed to me that the autoantibody subgroups would be helpful for that. And part of that was based upon the very simple clinical observation that if we take something like skin score or skin severity in diffuse systemic sclerosis, we know that the different autoantibodies have clinical associations that are different. We know, for example, that the anti-RNA polymerase antibody group of patients tend to have very, very severe and progressive skin early on that will tend, with treatment, tend to then regress, and sometimes even regress, even in a placebo arm of a controlled trial, even without treatment. So it's almost like a natural history of the skin in RNA polymerase positive patients with very severe progression early on, and then this sort of potentially spontaneous regression. Contrasting that with something like an anti-SCL70 patient, where there is a perhaps more grumbling skin that is perhaps not as severe early on, but will later perhaps become more significant and won't show the same spontaneous improvement. So this was really something that led us to undertake a prospective study of skin biopsies and integrated blood sampling. This was the biopsy study that we did and published some I think some quite nice papers from, that really tried to look at the skin gene and protein expression and separate them by antibody, because we know that there's a difference, and we could show in that relatively small cohort of patients we studied that there were different trajectories of skin between the antibody groups, but we could then map that back to the gene and protein expression. So it was very informative, and you may have seen the data, but just as a sort of top line finding, we found that we could define in the skin biopsies of these antibody-defined groups significant differences in key pathways that had already been implicated in systemic sclerosis. And what was interesting is that we could find pathways that in these early diffuse scleroderma skin biopsies were significantly upregulated, for instance, only in one of those antibody groups. And just a couple of examples that came from the papers that we've published. For instance, Wnt signaling was selectively and significantly upregulated in the early SCL70 positive patients, but not in the RNA polymerase 3 positive patients. PI3 kinase and related pathways were significantly upregulated in the RNA polymerase positive patients, but not in the SCL70 patients. And this sort of immediately kind of makes sense then of some of the data that come from our clinical trials, where we see different responses that are different between the major antibody subgroups. And, it's both a challenge, but also perhaps an opportunity. So I think the antibodies are telling us much more about the differences in the disease biology, at least allowing us to maybe sort of understand them better.
Exactly. So I'm glad you bring in the clinical trials, because of course we have seen, and everybody involved in clinical trials, even just as a center recruiting, has noted that this autoantibody specificity now emerge into inclusion criteria, into stratification criteria, or exclusion criteria. And this is, of course, based on what you said, what we mentioned on the role in being associated with a specific type of clinical outcome. But I think that after the paper that you have published with Christina, we could be ready to bring this a bit to the next level, where not only we use them as markers to enrich for clinical populations, for clinical outcome in populations, but to decide whether a new drug could be used in every patient with scleroderma, or it can be particularly effective in some group. If, based on what you say, if there was a drug specifically targeting PI3 kinase, would you use RNA pol as an enrichment criteria in that trial?
Yeah, so I think that's a great question, and one that we obviously discuss also with the companies and sponsors thinking about planning clinical trials. I think the first thing to say is that, as we know, systemic sclerosis trials are really challenging. And one of the challenges is that often if you take a group of maybe unselected patients, for instance, with diffuse scleroderma, you will see that your treatment works much better in some patients than others. And so I think the autoantibodies do help us to try and make sense of that, as I've said, and maybe understand if you've got a pathway that's more selectively upregulated, that would clearly be, I think, the starting point for your trial. I think the most important thing, though, and this is what I would always say, if I'm designing a study, if possible, I do think it's important to stratify your cohorts for antibodies, so you've got balance of the autoantibodies between your treatment arms in a trial. But I do think it's probably still worthwhile treating a broader group of patients with your intervention, and there are two reasons for that. First, in a necessarily small trial that you would be doing, in the early stages of clinical development, you want to be, have as many patients in the study as possible. But also, I think you can test the hypothesis both ways, because if you've got a group of patients where you could predict a greater response, you could actually pre-specify that in your analysis. So, for example, if you thought your pathway was more activated in SCL70 positive patients, you could pre-specify that might be a group that responds better. But you would want to, I would say, include a broader group of patients, because the other way of testing that hypothesis would be to confirm that there was a less response in the non-SCL70 positive patients. And I think if we're thinking for the longer term future for any treatment in systemic sclerosis, what you don't want to do is have a treatment that is too restricted, and therefore, not be able to potentially give it in the future to a group of patients who might benefit, even if they don't benefit as much.
I see your point. Yeah, that is a very valid point. And so in this sense, we've been using anti-centromer antibodies and exclusion criteria lately. It is based on what we know of the type of clinical outcome they have in 12 months, which is the usual duration of a clinical trial. what have you learned from the anti-centromere antibodies?
Yeah.
Because you have been the one that has been studying them most than anybody else.
Yeah, so I suppose taking a step back, in the same way that we kind of started the discussion around the antibodies that maybe have a particular increased risk of complications, SCL70 and lung fibrosis, polymerase 3 and renal crisis, for example. One of the things that struck us when we looked at our cohort patients, and others have confirmed this now, is that anti-centromere antibody in many ways could be seen perhaps as a protective antibody because it's associated even in diffuse scleroderma, and some patients with diffuse scleroderma skin have a centromere antibody, but if they do, they have a much lower risk of severe lung fibrosis, for example. So it's almost like a protective antibody. And maybe this also biologically explains why it tends to have this association with the limited subset of scleroderma. But I think for that reason, it is quite helpful to exclude patients with anti-centromere antibody in a trial of patients with diffuse cutaneous systemic sclerosis, because you would be reducing the risk of recruiting patients that are perhaps less progressive. And I think the other point is that the anti-centromere antibody is associated with limited disease. And in the early stages of systemic sclerosis and in clinical trials, people are often kind of really focusing on early disease. It's a little bit also of a way of making sure that you're not inadvertently recruiting patients with limited systemic sclerosis into your diffuse scleroderma trial. So I think the centromere antibodies are really good in the clinic because we can see them perhaps as a reassurance of a lower risk patient, but also helpful in trials to, again, make sure you're not recruiting patients that are not going to be informative.
Yeah, no, absolutely. And that's completely different, as you mentioned, when we look at vascular complication, but also those trials are different. And yeah, clinical trials. And this is how we've been using antibodies to design clinical trials. But now, also in scleroderma, we had this increasing wave of treatment options and trials targeting B cells and targeting autoantibody concentration. Yeah. So B cells are known to be the mothers of the cells that eventually produce the secreted antibodies. And people start to wonder how much of the clinical effect that we see is mediated by ablating or decreasing the concentration of autoantibodies. What do you think of this approach?
So I think that's a very important point. And unfortunately, I would say one of the very important translational medicine questions in systemic sclerosis that will, fortunately, I think, be addressed and unanswered to some extent by the trials that are either ongoing or planned, that are looking carefully at the potential link between clinical outcome and change and the level of the antibodies of the class of the sort of hallmark of autoantibodies that we've talked about in systemic sclerosis. But I think the other perhaps more relevant point is also the extent to which autoantibodies are part of the pathogenic process of systemic sclerosis. And what I would say with that is perhaps to just consider them a little bit more broadly, because I think it's possible that some of the autoantibodies we've talked about that we use to diagnose and stratify patients, like anti-SCL70, they may well have some direct role in pathogenesis of the disease, and there's some literature evidence, as you know, to support that. But others might just be markers, as we talked about. They might just be markers in a way of the immunogenomics of the immunogenetic landscape of that patient, but still relevant to the disease. But in all systemic sclerosis patients, it's possible that there are other autoantibodies that are not part of the diagnostic part of the disease, but are actually autoantibodies that are relevant because they're targeting cell surface proteins or structures that are relevant. So I think the concept of the autoantibodies being important in the pathogenesis of the disease is very relevant for treatments that target antibodies or B cells that produce the antibodies. But it's not just restricted, I think, to the antibodies, the autoantibodies we've been talking about in the first part of the podcast. Yeah. So, but as you say, a huge interest. We know in the clinic, we know from the recommendations from BSR, from EULAR, that B cell depleting treatments are part of the treatment landscape that we would use for our patients. We think this is helpful with drugs like rituximab, but the question is whether whether we can do better than that. And I think that's where we are with clinical trials, as many exciting ways to target B cells, perhaps the most targeted cell type at the moment in systemic sclerosis.
And the cells also targeting and the treatment targeting antibody. You're absolutely right. Thank you. Every time we discuss formally or less formally, Chris, is always very interesting and illuminating. Thank you. Thank you for your time. You're absolutely right. Antibodies will keep teaching us something. Well, and on this note, we are at time. Time flies when we discuss, and I hope you found this interesting. Please subscribe to this podcast. You'll find it on Spotify and on SoundCloud, and let us know what you think. We really want to discuss the topics that are most important to the community, clinical and translational and scientific community. You can also watch this podcast on the Scleroderma Forum website and on YouTube. And you can follow the Scleroderma Forum on X and LinkedIn so that you will be notified when new podcasts or webinars are happening. And stay tuned because we will keep discussing this in the new year with formal webinars. Thanks again for your attention and see you soon.